All right, guys. So, moving on with the lecture now, we talked about the initial neurological motor response that you will assess in a comatose patient. Now, moving on with the further things, an appropriate motor response that you would be looking for would be a person localizing, fending off any stimulus that you provide to the patient, like pain. For example, the patient might be withdrawing and might grimace all because of a nail bed pressure that you put on the patient or by doing sternal rub. And then we talked about the decerebrate and decorticate posturing, both of which suggest lesions at different levels of the brain and the brainstem. So anything above the midbrain, bilateral, that is enough severe to cause disruption of the reticular activating system or its connections will be causing decorticate positioning, whereas the one at the level of midbrain or below will cause decerebrate posturing. Um, so this might be important to know because of either transtentorial herniation in case of a supratentorial pressure from structural causes or even from metabolic causes at times. So don't think that there always a stroke or a structural lesion will cause these kind of posturing abnormalities. Even metabolic causes might do that, right? So, and then there's another motor response that you might see in patients, which means when the patient is completely flaccid and there is no motor response at all. Now, that would suggest a deeply comatose state, but it can also mean a structural lesion with cervical cord trauma, a brainstem stroke, which would result in blocked-in syndrome, or Guillain-Barré polyneuropathy. So, all of these things, all of these conditions will cause what? Complete paralysis of upper and lower limbs, right? So the patient won't be able to move his or her limbs at all and will be deeply comatose, right? Now we come to the respiratory patterns that you observe in comatose patients. There are different ways that I can describe that, but picture speaks more than 1,000 words. So let's look at these patterns here that I have shown. There is this Cheyne-Stokes breathing pattern in which you see that the patient in incremental fashion hyperventilates, right? And then after that, they start hypoventilating. And then immediately in between, there is an apneic episode. So they're not breathing at all. So this is a fluctuating pattern, right? Incremental, decremental, hyperventilating response interspersed with periods of apnea. Then you have the Kussmaul's breathing. This is usually a metabolic cause. This causes this kind of breathing. And you can see this is a regular hyperventilating pattern. And no incremental or decremental response is seen here. Then you have the Biot's breathing, another kind of abnormal breathing pattern, in which you see that the patient is breathing normally. There is no incremental, there is no decremental response, but then there are periods in between of apnea when the breathing is not there at all. And then there's another breathing pattern in which you see uh, an irregular hyperventilating, hypoventilating, and apneic episode breathing pattern. There is no pattern of this breathing at all, and this is also kind of a breathing pattern that you observe, and we'll discuss that in a while. So again, the chain stokes breathing. Now that is characterized by periods of hyperventilation and apnea alternating in a crescendo decrescendo pattern, and this would suggest bilateral cortical lesions as a cause, any cause of upper brainstem damage or metabolic encephalopathy, and this may lead to injury injuries, but it does not mandate ventilatory support. This is very important to understand. And a lot of times you might see such patients breathing abnormally, but once you have recognized that this is a pattern of breathing and not something else, you do not need to necessarily um, intubate them and look for the underlying cause and address that, and hopefully the patient will get better. Then there's another response, which is known as a sustained hyperventilation response. Now, it is just like the Kussmaul's breathing, or basically another name for that. Now, it may be because of metabolic causes, as I have suggested. The most classically, you see that in acidosis, and so the patient is breathing. Ultimately, there is respiratory muscle fatigue, and the patient, goes into respiratory arrest, becomes apneic, or just because of air hunger, deficiency of oxygen in the blood, hypoxia, which drives the respiratory center in a normal person. And then at that point, the patient becomes hyperventilatory. Yeah, the patient starts hyperventilating. Pulmonary congestion, which stimulates the receptors in the lungs, which then eventually causes stimulation of the uh, ventilatory center in the brainstem and causes hyperventilation. But then there is another classical pattern when you have ruled out all these causes, which is known as a primary hyperventilatory pattern. Now that will only result as a cause from brainstem damage, which shows respiratory alkalosis pattern. Okay. Then you got the ataxic breathing pattern. The ataxic breathing pattern is signified by a pattern consisting of periods of hyperventilation and apnea alternating with crescendo-decrescendo pattern. And such a pattern also reflects brainstem damage. And this one mandates ventilatory support. And as we have seen here, the ataxic breathing pattern is an irregular pattern. And yes, now you need to think about ventilatory support. It's important to know what kind of breathing pattern is seen in which kind of injury or insult as well. Again, if there is a lesion to the CNS or to the nervous system that is above the level of the midbrain, that is the diencephalon and the cortex, then it presents as the Cheyne-Stokes breathing pattern. Again, as I said, does not mandate ventilatory support. Okay, it might be suprasellar lesion, it might be a thalamic lesion, anything above this level. Then you have the hyperventilatory pattern. Now, again, metabolic causes, septic causes, all those ruled out. Primary hyperventilatory cause is going to be any involvement of the brainstem that will produce this, because you have the ventilatory center, vital centers over here. So they, if being affected, will cause this pattern to develop, and this mandates the ventilatory support a lot of times, along with involvement of the distal midbrain. Now, that is when you get the cluster, the biots breathing. These are all types of ataxic breathing patterns. If the distal medullary part or brainstem part of the brain is involved, then this is a poor prognostic factor, and it mandates ventilatory support if you want to make the patient survive for that time period. Although the prognosis is poor, obviously the life-saving treatment that you can do at that time, must do, is ventilatory support. Okay. So this is how you can kind of keep it in your mind. Cheyne-Stokes, hyperventilatory response, and ataxic breathing all the way here downstream. And obviously, if you can imagine, if you get a patient which has stroke here, and a stroke can cause compression of the midline structures or can cause pressure effects, will produce Cheyne-Stokes breathing. Eventually, the pressure effects increase so much so that the brain starts herniating. Here is the foramen magnum, and when the brain starts herniating the foramen magnum, you get effect in the brainstem, and the brainstem pressure ultimately will cause Cheyne-Stokes, hyperventilatory response, progressing to cluster and Biot's breathing, and that can cause, obviously, brain death ultimately.